Hi everybody, and welcome once again to another one of my USMLE high yield review lectures. And today we're going to do part 2 of rheumatology. Specifically, we're going to go into orthopedics and sports related rheumatology. So part 1 dealt with pretty much everything rheumatology. Here we're talking more towards orthopedic injuries and such. So let's get right to it. So first of all, we have radial head subluxation, which is your nursemaid's elbow. The radial head subluxation, the way it happens is that it's an axial traction that happens on the forearm with the elbow that's extended. So the child is pulled, lifted, or swung by the arms, and then that's how you get the radial head to be subluxated. It's also why it's called a nursemaid's elbow, because the nursemaids were the ones that take care of the kids. And they would constantly be yanking on the little kid's arm to pull the kid towards them, and then you'll have that subluxation. So on physical exam findings, the arm is going to be held in an extended and in a pronated position, and there's not going to be any type of swelling or deformities or focal tenderness. So when you try to attempt the forearm to supinate, the child will then try to resist and cry out in pain, but usually otherwise it's the patient's not in a lot of distress. It's just that the treatment is going to be to supinate the forearm and flex the elbow, or you can just hyperpronate the forearm and you can hear a pop. When you hear that pop, that means that the radial head has been reduced properly. Now this is common in children between the ages of 1 to 5 years old. And the response to treatment is also going to be diagnostic. There's no post-reduction films needed when the patient resumes full use of the extremity. You just hear that pop maybe, and or once he's able to use his arm, that's about all you need for to know that it worked or not. All right, so that was radial head subluxation. Next one is supracondylar fractures of the humerus, and elbow fractures are going to be almost 50% of all the fractures seen in children. So it's going to be in the elbow. Most common type is going to be your supracondylar fracture of the humerus. It's common in kids between the age of 2 to 12, and it's usually after an outstretched fall. So, well, when they fall with their outstretched arm and the elbows extended, kind of like think of it if they're like roller skating or skateboarding and they're about to fall on their face. They outstretch their arms to prevent the sidewalk or the pavement to hit their face. So the elbows extended, locked in, outstretched arm. Then you got your fracture of the supracondylar fracture of the humerus. X-ray is usually going to show a large triangular anterior fat pad lucency and a posterior fat pad lucency. So you'd have to see a picture of an X-ray to see that, but it just looks like the fat pad around the elbow is widened. It may be complicated by neurovascular injury, or it can even get to a compartment syndrome. Neurovascular injury is going to cause for you to frequently monitor their pulses, and compartment syndrome will progressively increasing pain especially with increasing swelling. Then you'd have to remove any kind of bandages and measure the compartment pressures and do an emergent orthopedic evaluation for a possible fasciotomy in those cases. So that's like the worst case scenario would be a compartment syndrome. Next up is growing pains. So growing pains are very common musculoskeletal complaint in children, and occurs approximately around 10% to 30% of children between the ages of 2 to 12. Those are your growth spurt years, right? It's also, the etiology is unknown, but they're unrelated to growth despite their name. So growing pains, apparently it's not the TV show, it's about growing and pain, but it has nothing to do with it. Isn't that confusing? Okay, next up. The diagnosis is clinically made in the absence of systemic symptoms and abnormal examination findings. And on lab studies and radiographs, those aren't necessary because you're not going to see anything. So clinical features of growing pains, again, you're going to see a kid between the ages of 2 to 12, and they're going to complain of pain that occurs primarily at night. and goes away by the morning. You see that, click growing pains, click and move on. It affects the lower extremities as well, like the thighs, the calves, and it's usually bilateral. So that's another reason why you're thinking maybe it's a growing pain problem, because bilateral extremities out of nowhere at night, you think you may be growing at night, possibly, but it has nothing to do with the growth. Normal physical examination and activity is also a clinical feature, so they're not going to complain about anything other than night pains that resolve by the morning. The treatment is just to educate the parents, reassure them, maybe even massages, stretching exercises, apply heat, and as well as analgesics. But you also want to follow closely and monitor for those pains, so that if those pains start increasing in frequency or in intensity, you'd want to further evaluate that. And children with growing pains often have lower pain thresholds and more depressive symptoms when compared to other children, but psychiatric evaluation won't be necessary in these patients. They're just like depressed because they're in pain all the time, right? I would be. Next is clubfoot echinovarus. So the definition here, echinus and varus of the calcaneum and the talus, with the varus of the midfoot and adduction of the forefoot. So etiology, there's either congenital causes, it could be teratogenic causes, or positional causes. The congenital is usually isolated and it's idiopathic, whereas teratogenic is usually associated with some kind of neuromuscular disorder or a complex syndrome. And then positional etiologies of clubfoot would be due to abnormal positioning of the affected foot in utero. How do you treat clubfoot? Immediately? Non-surgical methods like stretching and manipulation of the foot, followed by serial plaster casts, malleable splints, or taping. So if that doesn't really work, then you can move along and do surgical repair, and that's preferably done between the ages of 3 to 6 months of age. But always, you want to always do this before they reach a year old, so before 12 months of age. Now, this is a really important test question, because they just love to ask about clubfoot, at least on UWorld, and I did have a question on this on my actual exam. So I would pay attention to clubfoot. It's easy to just think you want to start manipulating that by surgery or whatever quickly, but actually it's not. It's non-surgical methods first, by stretching and manipulation of the foot. Then once you do that, then you do the serial plaster casts. You can do the splints or the taping. So it goes something like this. The kid comes out, he has clubfoot. What's the next step in management? Stretching and manipulation of the foot. Would you want to do malleable splints or casts, or do you want to surgically repair? And it's obviously you want to manipulate the foot by stretching and non-surgical methods, okay? So keep that in mind. The majority of cases respond to conservative management without the need of surgical repair, and untreated cases like further deformation and gait abnormality can develop, as well as ulcerations can develop, because it's just not in the correct alignment, so an ulcer can start developing. So that was clubfoot. All right. Then we have Metatarsus Adduction, and this is a congenital foot deformity. It's common in the firstborn child with no sexual predominance, so it's equally male or female predominance. So the adduction at the tarsal metatarsal joint with an increased angle that's seen between the first and the second metatarsals. 10% of those cases are associated with acetabular dysplasia, so a careful hip examination would be required with metatarsus adduction. There's 3 types: type 1, type 2, type 3. Type 1 is going to be a mild metatarsus adduction that's characterized by the feet that causes overcorrection of both passively and actively into an abduction. So spontaneously they're going to correct themselves and they don't really need further treatment. So that's a mild metatarsus adduction. That's type 1. Type 2 is a type of adduction that corrects into a neutral position by passively or active movement. And the treatment here would be orthotosis or corrective shoes, and sometimes plaster casts if the initial treatment fails, right? And then finally, type 3 is going to be a rigid foot with that does not correct. And here you want to first treat with serial casts, and surgical correction finally may be needed if it doesn't get better by the time they're 4 years old. So sounds familiar, right? Metatarsus adduction and to clubfoot. But remember, clubfoot needs to be corrected by the time before they reach 1 year of age versus metatarsus adduction. This needs to be corrected by 4 years of age. And that's like the worst case scenario. So the internal tibial torsion is also a physiological finding in newborns, as well as spontaneous correction occurs in 95% of cases with tibial torsion. All right, so that's a good thing. The majority just goes away by itself. All right, slipped capital femoral epiphysis is another highly tested one. So it's either going to be a normal, stable, or unstable femoral epiphysis, right? And this is going to be displacement of the femoral head on the femoral neck due to a disruption in the proximal femoral growth plate. Typically, it's seen in obese children 10 to 16 years old, so I guess you guys already know that, but you see an obese child with some kind of hip problem, you're starting to think femoral epiphysis, slipped capital femoral epiphysis. And the mean age of presentation is about 12 years in girls and 13 and a half years old in boys. And it happens more in adolescent boys than in girls. So an adolescent boy, 13 years old, obese, with displacement of the femoral head on the femoral neck, there's your slipped capital femoral epiphysis. So this happens because of a physical junction between the femoral head and the neck that weakens during early adolescence, and that's due to the rapid growth in that time frame. So it just grows rapidly without strengthening as fast as it's growing. So it's it is cartilage and it's not as strong as bone. So obesity makes everything worse. Just like in life, obesity just makes everything worse. Everything gets more difficult and causes a fracture. It can cause a fracture as well as a femoral disc to slip. Additional risk factors would be like endocrinopathies, such as hypothyroidism and growth hormone deficiencies, all of which can give you obesity, renal failure, and radiation history that can weaken the bone. And mostly it's bilateral, right? So because it's due to the growth and development. So but bilateral is going to be seen mostly. Signs and symptoms, it's going to be an insidious onset of dull hip pain or referred knee pain, as well as an altered gait with limping and no preceding trauma. So they didn't hurt themselves, they just started having a gait problem, starting getting hip pains, and a minor trauma can sometimes exacerbate that pain. So be careful with that. It's not going to be because of the trauma. The trauma is just going to exacerbate some pain that's eliciting something that's already there. There's a high degree of suspicion as knee pain, which is a referred pain, and not hip pain is a common presentation with this condition. Physical exam, patients are going to hold their affected leg in a passive external rotation and loss of internal rotation. Also, abduction and flexion, as well as an external rotation of the thigh when the hip is being flexed. The diagnosis, plain radiographs of the hip in the AP and in the frog leg lateral view are the ones that you want to do. So frog leg is always good for the hips. Posteriorly and inferiorly, medially displaced femoral heads in relation to the femoral neck. And both hips should be imaged for comparison and contralateral displacement. The treatment would be to immediately do a surgical screw fixation, like pinning, at current degrees of displacement. And the reason why you do that is to avoid avascular necrosis as well as chondrolysis. So that's another answer to a question is what do you do next? And it's surgical treatment with screw fixation or pinning or whatever. But you want to fixate that because it can get bad. It can cause avascular necrosis. So they like to ask that one, as well as the following one, the Legg-Calvé-Perthes disease. Now, this is an idiopathic avascular necrosis of the femoral head, which can be due to a thrombophilia in some patients, and it commonly affects boys between the ages of 4 to 10 years of age. The peak incidence is about 5 to 7 years old. The signs and symptoms are going to be mild chronic hip pain or knee pain of an insidious onset, as well as an antalgic gait, which is a shorter time weight bearing on that joint on the affected side due to the pain. Physical examination, as the disease progresses, abduction and internal rotation is markedly going to decrease, and proximal thigh atrophy may also be present. So the diagnosis is going to require a high index of suspicion, as the initial x-rays may be negative. That leads to the initial diagnosis and treatment of synovitis, which can often occur after a viral infection, but it goes away between 1 to 4 weeks because it's the viral infection. Persistent symptoms are going to require repeat imaging, and it can take months concerning those changes to appear on x-ray. So you're going to see on x-ray a flattening and a fragmented left femoral head. So it's kind of going to look like one of those French pastries that look like a little hamburger that's squished together, and they're going to be like little pieces coming out. The reason why I say a hamburger, because if you look at two buns and then the middle patty with I'm getting hungry now, but the patty with like the cheese flailing out and the lettuce coming out, those look like little fragmented pieces on x-ray. Geez, I'm comparing an x-ray like a pathology person would. Figures. Anyway, that's how you see it. Just check out an x-ray, and they will test you on this. I am 100% positive that you're going to see one of these on your exam. So these are very high yield. Legg-Calvé-Perthes disease is a big one. The MRI and the bone scans are going to show a subtle femoral head necrosis weeks to months earlier than an x-ray, and this is going to lead to an earlier diagnosis, so that's a good one, the MRI of the bone. And the treatment in general, these patients are managed conservatively with observation and bracing. The surgery may be indicated in cases where the femoral head is not well contained within the acetabulum. And the patient should refrain from weight-bearing exercises. I mean, if you see that x-ray, you wouldn't even want to stand. It looks so painful. All right, next one would be hip dysplasia, and this is about abnormal development in utero, obvious at birth, or it could be noticed later on with when they present with a limp. Could be a leg length discrepancy, and over time it can progress to a degenerative joint disease. An x-ray can show a poorly formed femoral head. And that's hip dysplasia. That's pretty much all there is to it. It's just a hip that just is out of whack. Next up is developmental dysplasia of the hip. Isn't that nice? Hip dysplasia versus developmental dysplasia of the hip. So he trips you up. It trips me up. Screening for developmental dysplasias of the hip occurs within the ages of 0 to 12 months, and the physical examination is seen at each well-child visit. So basically you're going to do the Barlow or Ortolani maneuver, right? So if you have a positive Barlow or Ortolani, you just refer to Orthopaedics. So asymmetry with a negative Barlow and Ortolani, then you got to find out how old are they? Are they between 2 weeks to 6 months? Because if so, they'll need a hip ultrasound. But if they're greater than 4 months to 6 months, they may require a hip x-ray. But see how those ages interlace there, intermix? You can either do ultrasound or hip x-ray. Usually they're going to have hip ultrasound in the vignette, and it's going to be like a 4-month-old kid. But if it's a good thing, if it's very early on, you want to do ultrasound. If they're older, hip x-ray. So the developmental dysplasia of the hip is a dislocation of the femoral head from the acetabulum. The early diagnosis is going to be critical because treatment initiation before the age of 6 months is going to give you a favorable prognosis. Delayed diagnosis is one of the most common reasons for malpractice suits against pediatricians due to potential complications such as like that lymph, which is the lymph is called the Trendelenburg gait. They can get scoliosis, arthritis, as well as avascular necrosis if not treated or picked up early on. So risk factors are going to be a patient who had a breech presentation at birth, females, white females specifically, and a family history of developmental dysplasia of the hip. All those increases the risk, and most patients have an approximate 75%. Or 75% have no risk factors. So those are the major risk factors, but the majority of patients with developmental dysplasia of the hip have no risk factors. So therefore, all infants have to have serial hip examinations from the time they're born until the time they're walking, which is around 1 year of age. So remember those Ortolani and Barlow maneuvers at each visit. The Barlow and Ortolani maneuvers should be performed to assess joint stability, and this is going to consist of placing the infant in a supine position with each hip flexed to about 90 degrees. And then you're going to follow that by abduction to feel for any kind of dislocation, and adduction to feel any kind of reducibility of the unstable joint. You're going to hear a palpable clunk with the maneuver if it's dislocated, and that's an alarming sign. It should have a prompt referral to an orthopedic surgeon. Equivocal signs such as a very soft click or a leg length discrepancy or any type of asymmetric inguinal skin folds, that can suggest a possible hip laxity and not necessarily a developmental dysplasia of the hip. And hip laxity that is present at birth usually goes away by 2 weeks of age. So imaging isn't really recommended until they're older than 2 weeks. Infants between the ages of 2 to 6 months with abnormal examinations then should do the ultrasound like we said earlier, and developmental dysplasia of the hip is going to be bilateral in only approximately 20% of patients. So both sides should be imaged independently. An x-ray isn't going to be helpful until they reach 4 to 6 months, and we all know the reason that is because the femoral head and the acetabulum haven't really ossified yet, so you're not going to really see anything on x-ray. There's no calcification there. So after you get ossification, the x-ray is going to be better at showing the acetabulum developing and the positioning. Otherwise, ultrasound is your best maneuver or imaging modality. So check out those Ortolani and Barlow maneuvers. I mean, I'm sure you guys have seen it or even performed it during some of your OB-GYN rotations or pediatric rotations. So check them out. A positive Barlow and Ortolani tests or any kind of abnormal imaging is going to, if you see any of that, you need prompt referral for treatment. And something called a Pavlik harness is a splint that's going to hold the hip in a flexed position and adduction, and this is going to prevent extension and abduction, which can exacerbate the dislocation. So you want to keep them flexed and adducted, and that's done with a Pavlik harness. It is the treatment of choice if they're younger than 6 months, and that's because most hip joints are able to remain in a stable position before then. After 6 months, however, the harness is far less successful, and reduction under anesthesia will then be required. A CT and an MRI can then be helpful in perioperative assessments of the affected hip, but it's unnecessary for your initial screening. Remember, you want to do ultrasound initially. Okay, next up we have your femoral neck stress fractures. And these are seen in athletes and in runners. So anytime you see a stress fracture, it's probably because of a high impact cause, and runners are the ones that are going to be the ones seen on examination. So any athlete or a runner is going to present maybe with a stress fracture. So here it's in the femoral neck. It's a gradual increase in the pain, especially with activity, and the pain is going to be in passive ranges of motion, especially external and internal rotations. All right. Next up, we have transient synovitis. This is the most common cause of hip pain in children. It typically occurs in boys between the ages of 3 to 10 years of age. Don't let it trip you up with growing pains, right? So this is transient synovitis. The cause is unknown, but it usually follows a viral infection or a mild trauma. The synovial inflammation will then cause pain, a decreased range of motion, as well as limping. And on exam, the affected hip is typically flexed. It's slightly abducted and externally rotated. And this position is going to maximize the joint space, thereby providing some kind of pain relief because of that maximizing of the joint space. So you're able to bear weight on it. So you want to perform labs to differentiate this from a septic arthritis, and you also want to assess the severity of the inflammation. So in contrast to septic arthritis, children with transient synovitis rarely are going to have fever or significant lab abnormalities. So what are some of the features of septic arthritis of the hip? Here you're going to have a fever that's more than 101 Fahrenheit, Celsius would be 38.5. Inability to bear weight with a white blood cell count that's greater than 12,000, an ESR that's greater than 40, and a C-reactive protein greater than 2. So that's going to be one of the big differences, is going to be the fever and the inability to bear weight. Ill-appearing febrile children with more than 3 or 4 of the findings shown in that table that I just mentioned are going to require immediate arthrocentesis and IV antibiotics. So 3 out of the 4 ones that I mentioned: fever, inability to bear weight, white blood cell count greater than 12,000, or an increased C-reactive protein or ESR. So you want to obtain plain radiographs to exclude any kind of bone lesions, fractures, and that leg-calf-Perthes disease. You want to do an AP and frog leg lateral view of both of the hips, and those should be obtained to compare both sides for any kind of subtle change. And no additional workup is going to be needed unless symptoms are persisting or they're getting worse. And the treatment for these patients first is rest and NSAIDs. You don't want to give them aspirin, remember, Reyes syndrome. And then you want to follow up in 1 week. This is really good also for step 3, because this is exactly what you need to type up for in step 3. It's a good case for it. Usually they're going to recover within 1 to 4 weeks without any kind of complications, and if they persist or worsen, then you want to perform an MRI probably, and you want to reconsider leg-calf-Perthes disease as a diagnosis. So you need to do that MRI, but usually they go away within 4 weeks. All right, that was transient synovitis. So that's a good way to remember it. Transient. It's not fixed, it's transient. It can go away. All right, so next one we have Posse Arthritis. So Posse Arthritis, or Posse Articular Onset, Juvenile Idiopathic Arthritis. That's the most common subgroup of a juvenile idiopathic arthritis. It's a serum anti-nuclear antibodies are going to be the only usual abnormality, which also doesn't tell you much. Serum ANAs. Those are going to be pretty much the only one that's abnormal. Although Posse arthritis can present with a morning limp, it typically occurs in female toddlers and rarely involves the hip. So that's all there is for Posse arthritis. I don't think there was a question on that on the exam. But anyway, those are going to be like the big ones: transient synovitis, femoral neck fractures, the stress fracture. Even though the stress fracture wasn't not that it wasn't important, but I didn't see anything. But I did see developmental dysplasia of the hip, leg calf perthes, and slip capital femoral epiphysis. So really go over those because you will be tested heavily on those, especially on UWorld. On the actual USMLE exam, I would probably expect one of each of those scenarios. So just some FYI. Okay, next up is going to be rickets. So in rickets, what is this? It's a vitamin D deficiency. So what are some of the risk factors? Maternal vitamin D deficiency is a risk factor. Also inadequate sun exposure. But the two most common risk factors are going to be increasing in skin pigmentation and patients who are exclusively breastfed. Why? Because there's no vitamin D in breast milk. So you kind of have to give that this as a supplemental vitamin. Clinical manifestations, craniotabes, or your ping pong ball skull is going to be seen. Kind of like a ping pong. I hate using the term ping pong. It's about the size of a ping pong, but it's like those little ping pong balls are so delicate. How can they cause any kind of harm? But anyway, it looks like they were just indented in the skull because it's just getting eroded, right? Craniotabes. Also delayed fontanelle closures are seen in rickets, and large skulls with frontal bossing. There's going to be costochondral joints, or your ricketic rosary, and long bone joints involved. That's your wrists being widened, as well as genovarum. So yeah, in rickets, you're going to see a lot of bone being eaten away. On X-ray, you're going to see osteopenia, cupping or fraying of the metaphyseal areas, and epiphyseal widening. On serum labs, calcium is going to be normal or it's going to be decreased, as well as phosphorus is going to be normal or decreased. Alk-phos, because it's getting all eroded out, it's going to be increased, and parathyroid hormone is going to be increased as well, but 25-hydroxy vitamin D is going to be decreased. Although breastfeeding is the gold standard of nutrition, less than 1 year, but exclusive breastfeeding or homemade nutrition are inadequate, have inadequate vitamin D. So the child needs to be taking fortified baby formula in conjunction to that, or given vitamin D 400 units daily to prevent rickets. The treatment of rickets is going to be vitamin D repletion within, with about 1,000 to 2,000 units a day. So that's rickets. It's basically vitamin D deficiency in kids. Next up, we have Osteogenesis Imperfecta, which is a most commonly inherited form of an autosomal dominant mutation. The specific gene is the COL1A1. I don't think that was important on my exam, but there you go. COL1A1 for Osteogenesis Imperfecta. It's a varying spectrum of severity. So there you have your mild type, which is your type 1, your moderate type, which is types 3 to 9, and you have even your fatal perinatal type, which is your type 2. Isn't that confusing? So anyway, suspect in anyone with blue sclera. So that's pretty much how they're going to ask you or show you a picture of a kid, blue sclera, click Osteogenesis Imperfecta, you're good. Hopefully. Other manifestations depend on the severity of the disorder. They can get recurrent fractures, easy bruisability, hypotonia, and hearing loss, but the intelligence is normal. The Dentinogenesis Imperfecta. Now this is in many patients can cause blue, gray to yellow-brown discoloration of the dentin, and you're going to see shining or through of translucent and weak enamel of the tooth. And both primary and permanent teeth are going to be affected with Dentinogenesis Imperfecta. I think you can figure that one out. They're talking about teeth. But don't let it trip you up. It sounds easy, dentinogenesis, but it sounds so easy that it sounds fake. But no, it's not fake. It's an actual disease. Would they ask you that on the actual exam? Doubtful. They'll probably keep it at Osteogenesis Imperfecta. Remember, just I'd hate to say this here, but it's better to say it. It's better to say it now than never. This exam is an examination of what you're supposed to be taught in med school as a general form of knowledge, right? You're not supposed to get into sub extremes of clinical classifications on this exam. Just, superficial subtypes and stuff like that. So it's a generalized knowledge base that you are to be given in med school. So Osteogenesis Imperfecta is what you should know for the exam. Dentinogenesis Imperfecta is something that is good to know, but I wouldn't put a lot of emphasis on it since you may not be asked that. It might be one of those wild type questions that differentiates the I don't know, the 280 versus a 300 on the actual exam. But yeah, it's just understand that as a general rule of thumb. There's always going to be some curveball questions there that you never heard of. Remember, don't get tripped up. Those are meant to be there to trip you up. But really, the majority of these questions, you can answer them, and you will answer them. Okay, so good. Next up, sorry about that little rant on the side, but you guys are going to do great. Just keep reviewing your high-yield information, and you're going to do good. All right, so next up is your Kawasaki's disease. So this is an acute vasculitis of the small and medium-sized vessels. The peak age is going to be between 18 to 24 months in almost all cases, less than 5 years, and rarely in adults. And it's greatest among the East Asian ethnicities. How about that? Kawasaki's disease in Asians. All right, it's persistent release of pro-inflammatory cytokines causing prolonged high fever, and it's with a minimal response to antipyretics, like give them Tylenol, it really doesn't work, irritability, and systemic inflammation. The diagnosis is going to be on the clinical grounds, and that's going to be a fever for more than 5 days, and any of four of the following. So there's a great picture on UWorld, this little girl with all these features that I'm going to go over. So check that out. It's usually unilateral at the least consistent findings. Why did I read that? Okay, so anyway, fever for 5 days is going to be, the number one is going to be bilateral non-exudative conjunctivitis. So conjunctivitis is a feature for Kawasaki's. The other one is mucocystitis, which is erythema or fissured lips, and that strawberry tongue, which is a classic one, and the injected pharynx. In the heart, there could be signs of coronary artery aneurysms. They love to ask that. They can also have swelling or erythema of the palms and the soles of the feet. And the way I like to remember Kawasaki's is that just picture yourself sitting on a Kawasaki motorcycle. I'm sure you guys have heard of this one before. If you're sitting on a Kawasaki motorcycle, any motorcycle really, but let's say Kawasaki's disease for obvious sake, you're on a Kawasaki motorcycle, where are your feet and hands? They're on the pegs and on the grips. So where are the rashes seen in Kawasaki's disease? On the palms and on the soles. Go figure, right? That's kind of cool. I like it. So next up we have a rash seen throughout the body. Cervical lymph nodes are going to be greater than 1.5 centimeters, and those cervical lymph nodes, those are usually unilateral. But that's the least consistent finding for Kawasaki's. But just remember lymph nodes. I have been seeing it on UWorld. I didn't really notice it too much on my actual exam. On my actual exam, I just saw fever, coronary artery aneurysm, swelling of the hands and feet, and a strawberry tongue. Boom, Kawasaki's. But cervical lymph nodes are also going to be seen. And remember that fever, very very chronic kind of fever, like for more than 5 days. Patients with atypical presentations of Kawasaki's, you want to give them support with the following labs. So elevated C-reactive peptide and ESR, leukocytosis with neutrophilia, as opposed to lymphocytosis seen in viral infections. So this could look like a viral infection, but there's not going to be lymphocytosis. There's going to be leukocytosis with neutrophilia. Also reactive thrombocytosis and sterile pyuria on urine analysis. What are some of the differentials for Kawasaki's? This is a big one. Scarlet fever, it has a similar presentation because it also has a high fever, strawberry tongue, and a rash. And they have cervical lymphadenopathy, but they don't have the ocular manifestations, and they don't have, and the pharyngitis is more common, as well as a sandpaper rash that spares the palms and the soles. So if you don't have a rash on the palms and the soles, it's not Kawasaki's. Think something else. In this case, maybe think scarlet fever. Another differential would be staphylococcal scalded skin syndrome, which is more common in newborns. Here they present with a fever, a rash, and irritability, and they also get diffuse erythema that typically begins around the mouth and spreads rapidly throughout the body. But they also get flaccid blisters between 1 to 2 days after in flexural areas, and they also get a positive Nikolsky sign, which is the slough off those blisters. So no blisters in Kawasaki's. That's staphylococcal scalded skin syndrome. Then you have your hand, foot, and mouth disease, where you have fever, vesicles in the oral mucosa and the tongue, as well as small tender and cutaneous lesions on the palms and soles. But this here is caused by the Kawasaki virus. So because of it's a virus, you're going to see lymphocytosis with hand, foot, and mouth disease. And it's they're mostly going to ask you what virus it is, and it's Kawasaki virus. And it's self-limited within 2 to 3 days for hand, foot, and mouth disease. So those were your differentials for Kawasaki's. Hand, foot, and mouth disease by Kawasaki, staphylococcal scalded skin syndrome, and scarlet fever. All those are kind of similar. They have their own little points to remember, but that's what you should do. Okay, next, the treatment for Kawasaki's. Aspirin. Aspirin is going to be the one that they love to ask because you never give aspirin to a kid, but in this case you do. Aspirin plus IV Ig, immunoglobulin. That's preferably started within 10 days of symptom onset, and that's given to prevent complications. Systemic inflammation is going to resolve within 12 days if untreated, but that can lead to cardiovascular complications. So an echo is going to be performed at the time of the diagnosis, and it's also going to be repeated 6 to 8 weeks later to look for changes that may require close monitoring and prolonged therapy with Kawasaki. So remember that cardiac connection with Kawasaki's, and that you give them aspirin and IVIG. And because it has cardiac complications, you kind of want to do an echo. Complications are going to be coronary artery aneurysms, and they can also get myocardial ischemia and infarction. So heart attack in a little kid, not cool at all. Next up, so that was Kawasaki's, is acquired torticollis. So what is torticollis? This is also known as Rheumatology syndrome or Rheumatology, which is a neck twisting due to an asymmetric muscle activity. Its most common causes are going to be upper respiratory infections, minor traumas, and cervical lymphadenitis. And more serious causes can cause retropharyngeal abscesses, as well as atlantoaxial subluxations. That's not good. Cervical spine radiographs should be obtained in children that present with torticollis, and that's used to ensure that no spine fractures or dislocation is seen that is going to require some kind of extreme caution with acquired torticollis. So just a neck twisting. Next up, we have atlantoaxial instability that's seen specifically in Down syndrome patients. So 10 to 15% of cases with Down syndrome are going to have atlantoaxial instability. 1 to 2% of those are going to be symptomatic. This always kind of gives me chills, but it's excessive laxity in the posterior transverse ligament, specifically causing an increased mobility between the atlas and the axis, C1 and C2. Isn't that creepy? The symptoms would be progressive over several weeks and result from compression of the spinal cord, causing behavioral symptoms. It can also cause torticollis, urinary incontinence, and vertebro-basilar symptoms like vertigo, dizziness, and diplopia. On physical exam, upper motor neurons symptoms like leg spasticity, upgoing plantars, and hyperreflexia and clonus are going to usually be present. Down syndrome patients are normally hypotonic, and they remain hypotonic, or they can actually have an increase in tone due to an upper motor neuron lesion sign. And the diagnosis is going to be suspected on physical exam and diagnosed with lateral radiographs of the cervical spine in a flexed and extended position, as well as in a neutral position. So you kind of want all three of those positions on lateral cervical spine x-ray. An open mouth radiograph is also helpful to visualize any kind of odontoid problems. And the treatment is to surgically fuse the first and the second cervical vertebra. Oh gosh, that's just like so creepy to me, the C1 and C2 instability. It's kind of like crazy. Not like anything else in medicine is, right? But anyway, go figure, that's what creeps me out. Axial instability. All right. And that's seen in Down syndrome. That's a big one. Okay, so next up is spondylolisthesis. And this is a chronic back pain, common in adults, and it usually is benign in nature. But the chronic back pain in children needs careful search of a cause, because the back pain in children is usually due to some kind of an organic cause. Spondylolisthesis is a developmental disorder, and it's characterized by a forward slip of the vertebra, and that's usually seen through between L5 over S1. And it is usually present in pre-adolescent children with chronic back pain and neurological dysfunctions in combination with palpable step-offs at the lumbosacral area. Those step-offs are going to be palpable if the condition is severe. So that was spondylolisthesis. These are the step-offs in the lumbosacral area. And they're palpable. It's an easy one to identify in the exam. Next up, we have lytic bone lesions in children. And the differential diagnosis for lytic bone lesions in children would be infections like Brody's abscesses from an osteomyelitis. There could be endocrinous causes like hyperthyroidism or osteitis fibrosis cystica. And neoplastic ones like Ewing sarcoma, Langerhans cell histiocytosis, and metastasis. It could also be idiopathic, like a benign bone disease, aneurysmal bone cysts, and it could also lytic bone lesions with hypercalcemia can also be a differential diagnosis. Hyperparathyroid states like a parathyroid adenoma is the most common cause of primary hyperparathyroidism, and that's going to occur in patients more than 50 years old, as well as lytic bone neoplasms. So those were the bone lesions and lytic bone lesions in children. And then finally, your Langerhans cell histiocytosis. This is also known as Langerhans cell granulomatosis or histiocytosis X. These cause a solitary lytic long bone lesions with an eosinophilic granuloma. It's the least severe form of histiocytosis X. It's generally in children and in young adults, and they're going to have solitary bone lesions. They may be painful, or they can have overlying tenderness and swelling, as well as pathological fractures involved, and may be locally destructive, typically that resolve spontaneously, and therefore they're regarded as benign, and they're treated conservatively because they'll just go away on their own. That was Langerhans cell histiocytosis. Some pointers here is that the most common cause of osteomyelitis in children is going to be hematogenous seeding by Staph aureus. That's an important one. It tends to have episodes. The episodes tend to affect the metaphysis of the bones, and they're going to spare the epiphysis. Okay, so that's the major pointer there. Osteomyelitis in children, most likely cause is Staph aureus due to seeding, hematogenous spread. And then it affects the metaphysis and spares the epiphysis. Okay, moving on, we have orthopedics and sports surgery. So we were talking about pediatrics in the previous one. So now we're going to just do a quick one on surgery. It's a really quick one. And luckily, this is probably going to be under 1 hour. So this is awesome. Quick little review here. So anyway, rheumatology for orthopedics and sports surgery. Stress fractures. So stress fractures, risk factors would be repetitive activities like running or gymnastics. Also abrupt increases in physical activity with inadequate calcium and vitamin D intake. Also decreased caloric intake. A female athlete that has low caloric intakes and hypomenorrhea or amenorrhea, as well as low bone density. All those are risk factors that can lead to a stress fracture. Clinically, the presentation is an insidious onset of localized pain, so they're going to have local swelling and point tenderness at the fracture site. The x-ray can be negative in the first 6 weeks. So just because you don't see a stress fracture on an x-ray doesn't necessarily mean that there isn't any. And the management is reduced weight bearing for 4 to 6 weeks, rest, right? And referral to orthopedic surgeon for fractures that are at high risk for malunion. So some of these would be like an anterior tibial cortex fracture or a fifth metatarsal fracture. These fractures they don't really have a good union, so these are going to be referred for orthopedic surgery. So remember, like we said earlier in pediatrics for rheumatology, that stress fractures are due to like an athlete, somebody who's running high impact exercises. The bone is going to respond to mechanical stress by remodeling, but they're going to have an abrupt increase in the intensity, duration, or the frequency of physical activity without adequate rest. So let's say you just immediately started running. In other words, repeated tension or compressive stress to that bone will lead to microfractures that eventually coalesce with the cortical bone. It's characterized as activity related, so excessive training, improper footwear, biomechanical, like weak calf muscles or high arched feet, or it could even be metabolic. So there can be demineralized bone from a hormonal problem or a nutritional disease, sudden increases in repetitive tension and compression without adequate rest. And eventually that's all going to break down the bone and cause stress fractures. The tibia is your major weight-bearing bone in the leg, and the patients are usually going to develop medial tibial stress fractures. And those are medial tibial stress syndrome, which are your shin splints with no tibial tenderness on palpation. Further activity is going to complicate the fracture by causing a complete or incomplete fracture that can result in pain to palpation of the tibia. Classically, it occurs in the anterior portion of the middle third of the tibia in jumping sports, and posterior medial and distal third of the tibia in runners. So metatarsal stress fractures, these are going to be non-displaced hairline fractures. These typically occur in athletes and in military recruits. So metatarsal for military. Due to sudden and drastic increases in activity, the second metatarsal is the most commonly involved, and it's subject to significant extremes of loading during gait. So slow onset of foot pain initially with activity, but later during rest as well. Point tenderness over the affected metatarsal is seen, and on bone scans and MRI, those are done if you do an x-ray that doesn't demonstrate any kind of fracture. So if you're thinking that has a fracture because of all these comorbidities, and you do an x-ray, it doesn't come out, remember that you're not going to see a fracture on an x-ray in up to maybe 6 weeks. So in these cases, an MRI would be done instead. So fractures of the second, third, and the fourth metatarsals, these are managed conservatively because the surrounding metatarsals act as splints, and non-union is uncommon within the second, third, and fourth. But remember, like we said, the fifth one is the bad one because it needs orthopedic surgery. Rest and pain control are going to be the most important with the second, third, and fourth metatarsal fractures. Heart, sole, shoes, and light activity may be resumed immediately. Plaster casting can be used for patients with more persistent pain following conservative treatment. The fracture of the fifth metatarsal, that's a surgical intervention reserved for the fracture of the fifth metatarsal, such as the Jones fracture or a displaced fracture. Remember that it's not a very good fracture that goes away on its own because it doesn't reduce very easily. So you need surgical intervention. Diagnosis is made clinically on examination with pain at the specific area, increased with jumping or running, and associated with local swelling and point tenderness to palpation. X-rays are frequently going to be normal, like we said earlier, and they can reveal periosteal reactions and sites of fractures. So the best tests are going to be like MRI of the bone or a bone scan. And the treatment for these stress fractures is going to be rest and healing. And then next up we have hip fractures. These can be intracapsular, like a femoral head or neck fracture, or it could be extracapsular, like an intratrochanteric fracture or a subtrochanteric fracture. So the intracapsular, these are at higher risks of avascular necrosis. The extracapsular are at greater need of implants like nails and rods. So extracapular, those are going to need the nails and the rods. Intracapsular are the ones with avascular necrosis. Surgical repair should be done as soon as soon as possible to reduce pain and minimize complications and reduce the length of the hospital stay. The surgery can be delayed up to 72 hours to address unstable comorbid conditions, but longer delay is associated with more complications, obviously. And surgical traction has been advocated in people who do require a delayed surgical repair, but it does not relieve the pain. So delayed surgical repair doesn't relieve the pain or improve the surgical outcomes. You need to do surgical traction. So that was hip fracture. Next up is clavicular fractures. This is one of the most commonly injured bones, the clavicle. It's mostly injured in the middle third. So if they ask where is it located, where's the most possible location, I think I did see a question like that. It's the middle third of the clavicle. It's classically done during athletic events and mostly after a fall on an outstretched hand or a direct blow to the shoulder. Signs and symptoms would be pain and immobility of the affected arm, and that's going to cause contralateral hand. The contralateral hand that is classically used to support the weight of the affected arm. The shoulder on the affected side is going to be displaced inferiorly and posteriorly. Careful neurovascular examination should be done due to the close proximity of the subclavian artery. So they like to ask that one. So you'd want to perform an angiogram in these patients, as well as brachial plexuses can also be injured. So a motor examination of the arm and of the hand is usually sufficient enough to see if the brachial plexus is injured or not. And rarely you can do a nerve conduction study. But the subclavian artery is the one that they ask you about. So angiogram is good for that. The brachial plexus can also be injured, but the motor exam of the arm and the hand is usually sufficient to see if the brachial plexus was injured. The treatment of a clavicular fracture, this is going to be an interesting one, but fractures of the middle third Since it's the most common, it's usually treated non-operatively with a brace. So ice and rest. The early range of motion and strengthening is recommended to prevent the loss of motion at the shoulder in non-operative cases. And if the fracture is in the distal third of the clavicle, then you're going to need open reduction and internal fixation to prevent non-union. So hopefully that's not the case. The most common is going to be the middle third. All right, so that was clavicular fracture. And then we have supracondylar fractures of the humerus. The mechanism here is a fall on an outstretched hand. That's the most common. Complications would be brachial artery injury, median nerve injury, cubitus varus deformity, even compartment syndrome leading to Volkmann's ischemic contractures. And it's going to be one of the most common fractures in the pediatric population, the supracondylar fractures of the humerus. Like we said previously, it's common because the supracondylar area is thin, it's weak, it's due to physiological remodeling in childhood. Compartment syndrome can be an adverse outcome with the supracondylar fracture of the humerus. So ischemia and infarction from compartment syndrome will lead to a Volkmann's contracture. Limb length discrepancy is going to be a common complication of the proximal humerus and of the distal forearm. However, the distal physis, which is your growth plate of the humerus, is going to contribute very minimally to the longitudinal growth due to limited remodeling in that area. So as a result, patients with supraclavicular fractures of the humerus are at increased risk of cubitus varus deformities. So remember that Volkmann's contracture kind of looks like almost like a swan neck deformity in rheumatoid arthritis or something like that. But that's what it looks like. Check out some pictures of that. And the cubitus varus deformity kind of looks like a laterally displaced forearm. So the treatment is going to consist of analgesia and immobilization. Displaced fractures are going to require orthopedic consultations. Neurovascular injuries can often resolve after orthopedic alignment and immobilization. So if there was any kind of neurovascular injury, as soon as they're reduced and immobilized, that takes care of that. And obviously it's treated promptly because you want to avoid avascular necrosis. And anyway, it leads to a very good prognosis. And then we have scaphoid fractures. So scaphoid fractures are the most common fractures of the carpal bone, the scaphoid. It's usually across the waist of the scaphoid bone. Proximal fracture and fragments are vulnerable to avascular necrosis, and that's due to the blood supply in that area. So after a fall on an outstretched arm with a dorsiflexed wrist at more than 95 degrees. So the signs and symptoms are going to be pain at the wrist joint with tenderness at the anatomical snuff box, most sensitive. Just in case you guys don't know what the snuff box is or why it's even called the snuff box, it's like a little triangular region between the index finger and your thumb. And well, it's called the snuff box because it causes a little indentation in there where back in the day, and by back in the day I mean like the 1800s, you used to put in something called snuff, I guess. I'm not sure what it was. I think it was like a minty thing. But anyway, you put it there so you're able to inhale it. And that's why it's called the snuff box. I guess that's interesting. All I hear is crickets after that. But anyway, sorry about that. Minimally, it causes decreased range of motion unless it's dislocated, and there's also going to be a decrease in grip strength and possible swelling. The diagnosis, you're going to want to do plain x-rays of the scaphoid, full pronation and ulnar deviation to better expose the scaphoid are necessary to avoid a missing fracture. And the initial x-ray may be normal or show radiolucent lines in non-displaced fractures. So displacements of less than 2 millimeters and no angulation, for example. Treatment would be to immobilize the wrist with a thumb spica cast in all non-displaced cases suspected or proven fractures for 6 to 10 weeks to avoid non-union. And you want to repeat that x-ray in 7 to 10 days, so like a week later, and perform an immediate advanced imaging like a CT or MRI if the patient can't tolerate immobilization or immediate diagnosis is needed to distinguish the fracture from a ligament rupture. Fracture displacement will then require open reduction and internal fixation. So that was a scaphoid fracture. Then you have your sprains, like a minor ligament sprain. This is just your RICE treatment, rest, ice, compression, and elevation. And then finally, we're going to talk about compartment syndrome. So the compartment syndrome is due to an increase in pressure in the compartment due to edema and or bleeding. It's commonly found in the forearm and in the calf, but it can occur anywhere, right, in any kind of compartment. So clinical features of compartment syndrome are going to be pain that's out of proportion to the injury, pain that's increased on passive stretching, rapid increasing and tense swelling, and paresthesia early on. Uncommon clinical features would be a decrease in sensation, motor weakness within hours, paralysis later on, and decrease in pulses is very uncommon. Remember the 5 P's: pain, pallor, paresthesia, pulselessness, and pressure. And this is really common, by the way. This is very common, and you always want to put this on your differential diagnosis every time you get like a crush injury or a smashed finger or whatever. Compartment syndrome is really common. So predisposing risk factors would be direct trauma, prolonged compression of the extremity, and recent revascularization after an acute limb ischemia. Considerable variations in signs and symptoms and high indexes of suspicion is needed to make the diagnosis. The diagnosis is confirmed by measuring the compartment pressures in the affected extremity, but in high-risk patients like limb revascularization, this can be diagnosed clinically by signs of compartment syndrome like pain, swelling, and paresthesia. So what is the time to fasciotomy? Most critical prognostic indicator should be performed early on, the fasciotomy. Supportive measures are taken to maintain perfusion pressures by keeping the limb at level to the torso. You don't want to keep it higher or lower. You always want to keep it at level of the torso. So time to fasciotomy is going to be the answer choice in patients that you're thinking compartment syndrome. And that's it, guys. That is the end of rheumatology. Thanks for watching or listening in on this last rheumatology video lecture. I'm going to be posting another one pretty soon on a different subject. I might just do infectious diseases next. But yeah, I have a bunch of other videos on other subjects. So thanks again, guys, for all your support. Thank you for all the kind words. Again, I wish you all the best on your examinations. I hope this is useful to you, and hope to see you guys soon, and listen in on your comments. Any comments you might have, things that you want me to say, or anything in particular, just leave it down in the comment section. And I usually try to get back to those comments ASAP. But I do answer almost all the questions. So yeah, guys, thanks again for everything, and I'll see you guys on the next one. Thank you and good luck.